મિતેશભાઈ, હવે
હમ.
તમારા પેનલમાંથી હજુ બે જણ બાકી ને આવવાના.
हाँ हाँ एमने फोन कर दिए।
હમ.
रोहित, जिगर
નેક્સ્ટ.
को लगा, मैं पलक को बोलता हूँ।
हाँ सर।
અને તમે સ્ક્રીન શેર કરીને એકવાર ચેક કરવો તો કરી લેજો તમારે પીપીટી સાઈઝ.
कर दो, 1 मिनट उभा रहो।
હા હા, કઈ કઈ
ओके, आई गयो।
આવી રહ્યું છે. હા, હવે પેલું
आई
ફૂલ
गयो।
સ્ક્રીન કરી દેજો.
हाँ
હા,
हाँ।
આવી તો ફૂલ સ્ક્રીન કરીને જોઈ લો.
हाँ, आई गयो ना फुल स्क्रीन।
ના ના, નહીં આવે કારણ કે એનેબલ
હવે
એડિટિંગ કરવું પડશે પછી.
આ
હા, આવી ગઈ.
ફૂલ સ્ક્રીન નથી આવ્યું?
હવે આવી ગઈ, આવી ગઈ, આવી ગઈ.
હા, ઓકે ઓકે, સ્ટોપ શેર કરી દઉં છું અત્યારે.
હા, હમણાં સ્ટોપ છે.
હમ હમ. હા, ઓકે.
टू ने थ्री करे છે હા હા કેટેગરી 1 2 3 આવે કેટેગરી
ગુડ ઇવનિંગ.
ગુડ ઇવનિંગ.
ગુડ ઇવનિંગ મેમ.
ગુડ ઇવનિંગ જીગરભાઈ,
ગુડ
કરીમભાઈ.
ઇવનિંગ. આજે બહુ લેટ થઈ ગયું છે હેક્ટિક શેડ્યુલ.
આજે હમણાંથી થોડું સીઝન છે ને એટલે ઓપીડી માં લેટ થઈ જાય છે.
9 ને 5 જેવું થાય છે સર સ્ટાર્ટ કરતા હા ને.
હમ.
થોડા લોકોને જોઈન થવા દઈએ, 8 જ પાર્ટિસિપન્ટ છે.
હા એટલે જ ને 9 ને 5 જેવું થશે
હમ.
થોડું વાઇટ કરીએ.
અચ્છા, મિતેશભાઈ, પેલા કૃષ્ણ મોહન સાહેબ અત્યારથી જોઈન કરી લેવાના છે
હા હા, કરી દઉં.
એટલે એમને વેલકમ કરી દો.
હા સર. હા,
એટલે
તો
ફ્લોમાં
5 મિનિટ જોડો.
એન્જલિકાબેન,
હા
ફ્લો ડાયરેક્ટલી જે આપણે કરી છે તે પ્રમાણે પહેલા પ્રેસિડેન્ટ એઓપી ગુજરાત,
હા
પછીથી નેશનલના જે બી અવેલેબલ હોય તે,
હા
પછીથી સ્ટેટ લેવલના ઓફિસ બેરર, પ્રેસિડેન્ટ સેક્રેટરી, પછી કોઓર્ડિનેટરમાં ડોક્ટર મિતેશભાઈ, આટલા જણનું આવશે ને છેલ્લે મારું.
ઓકે ફાઇન. અને પેલા એક્સપર્ટ ને ખાલી વેલકમ કરી દઉં ઇન્ટ્રોડક્શન કરીને, એમનું
ના,
સ્પીચ નહીં.
નેશનલ લેવલમાં આવશે ને ઓફિસ પાસ ઓફિસ બેરર.
ઓકે, તો એમને એમનું 1-2 લાઈન નું સ્પીચ કહી દઉં ને.
હા હા, વેલકમ.
ઓકે, એટલે આપણે પહેલા સ્ટાર્ટિંગ વિથ ખમાર સાહેબ, પછી આપણે કોઈ બી નેશનલ ના ફેકલ્ટીઝ હોય તો એટલે આપણે યોગેશભાઈ કે કોઈ આવે તો એ, પછી કૃષ્ણા મોહન સાહેબ, પછી તમારું અને મિતેશભાઈ નું, બરોબર?
મારું છેલ્લે.
તમારું છેલ્લે, ઓકે. અને એવું બોલું કે આપણે અમારું ઇન્સ્ટોલેશન હમણાં એલર્જી ચેપ્ટર નું થયું રિસેન્ટલી.
હા હા હા, યસ ઓફકોર્સ.
હા, ફર્સ્ટ વેબિનાર છે, એટલે સેકન્ડ ઇવેન્ટ છે, એક કોન્ક્લેવ અમારે ત્યાં અમદાવાદમાં થઈ હતી 3rd ઓગસ્ટે, એલર્જી કોન્ક્લેવ.
એબ્સોલ્યુટલી યસ, એબ્સોલ્યુટલી યસ.
મિતેશભાઈ ટીટી રમવા ક્યારે આવો છો?
હવે તમે ટુર્નામેન્ટ રાખો ત્યારે. અમે રોજ રમીએ જ છીએ અહીંયા સવારે તો.
બરાબર.
મજા આવી હતી દિવસે બરોડા.
હા
આ સમીરભાઈ ડિફેન્સિવ પ્લેયર છે, હું ઓફેન્સિવ છું.
હા હા, મજા આવે બંનેની મેચ જોવાની પણ. બહુ
બહુ
સરસ.
મજા આવી.
બહુ મજા.
સમીરભાઈ બીચ પર છો કે પાછળ ગોઠવ્યું છે સરસ.
તો ગોઠવેલું જ હોય.
માસ્ટર છે તો ટેકનોલોજીમાં.
આપણે મજા તો લઈએ એની, ભલે
સાચી.
પહોંચી ના શકે. જીગર ખમાર સાહેબને
I
ફોન
am
કર દે.
sending very famous. કરી દઉં. હા. હમ. હમ.
કેમ છો? ગુડ ઇવનિંગ એવરીવન.
ગુડ ઇવનિંગ જંગતામાં.
હા. હમ.
હું જરાક એક કોલમાં છું, પછી વિડીયો ચાલુ કરું છું. કોલ.
હા હા. અરોપ રોય સાહેબ, ગુડ ઇવનિંગ.
Good evening, good evening, good evening. Samir, good evening.
ગુડ ઇવનિંગ સર.
Good evening, good evening.
અમાર સર ઉઠાવતો નથી.
થશે જોઈન કરતા.
પરિન સર, તમે ક્યાં પ્રેક્ટિસ કરો છો?
રાજકોટ.
પરિન રાજકોટ થી છે.
એટલે એમનો સીવી નથી આવ્યો, ખાલી બીજું બધા.
પરિન એકદમ હોલી પર્સન છે.
ગુડ
એ વોટ્સએપ નથી વાપરતા.
હા.
એ વોટ્સએપ નથી વાપરતા.
હા, પરિન વોટ્સએપ નથી વાપરતો. પરિનનું એક વન ઓફ ધ મોસ્ટ ઇમ્પોર્ટન્ટ થિંગ ઇઝ કે પરિન નેવર ચાર્જીસ. ખાલી એની કન્સલ્ટિંગ રૂમમાં લખેલું હોય કે જેને આપવું હોય એ આપે, જેની જેટલી ઈચ્છા હોય. ને ઇઝ અ વેરી નાઇસ પર્સન એન્ડ હોલી પર્સન.
એકદમ જેન્ટલ છે.
હા, યસ, વેરી જેન્ટલમેન. હાય પરિન, આવી કે પરિન તે જોઈન, પરિન જોઈન કરી લીધું છે?
યસ
બધું deliver. કેમ છે પરિન?
યસ મેડમ.
મોજા સીઝર કોલ માં છું એટલે હજી બેબી આવ્યું નથી.
સાંભળ્યું એટલે મીટ નો કર્યા.
યસ. ઓકે ઓકે ઓકે.
ઓકે, એટલે મારી સીવી શેર કરું, એટલે કે પીડિયાટ્રિક એલર્જીસ રાજકોટ ચાલશે. અને ઇન્ટિગ્રેટિવ મેડિસિન સ્પેશિયાલિસ્ટ. એટલે મારું વર્ક એકચ્યુઅલી ઇન્ટિગ્રેટિવ મેડિસિન અને પીડિયાટ્રિક એલર્જી બેમાં ફોકસ છે.
ખમાર સાહેબ, ગુડ ઇવનિંગ.
ગુડ ઇવનિંગ, બોલો.
આપણા ફેકલ્ટી નથી છે પલકભાઈ?
એના પર ટ્રાન્સફર કેમ નથી થતું?
પલક આવી તો ગયો છે, પણ એટલે ભાઈ એને નામે નહોતું ચેન્જ કર્યું, મેં કર્યું છે.
આવી ગયો.
પેજ ફરતું નથી.
કૃષ્ણ મોહન સર, વેલકમ.
Hi sir, good evening.
કૃષ્ણ મોહન સર, ગુડ
Good
ઇવનિંગ.
evening.
ગુડ ઇવનિંગ
Yeah.
મિતેશભાઈ.
ગુડ
ગુડ
ઇવનિંગ
ઇવનિંગ
સર.
જગદીશભાઈ.
બોલો બોલો બોલો, કેવું છે?
Hi Rohit ji, good evening.
ગુડ ઇવનિંગ.
ગુડ ઇવનિંગ ક્રિષ્ના, હાવ આર યુ?
Hi sir, I'm fine. Sir. Parin sir.
યા, હાવ આર યુ?
Yes.
Yeah.
ગુડ ઇવનિંગ સર, વેલકમ.
Hi. So Mitesh ji, please start the meeting when it is time. I will be online. I am traveling. It will take me another 10 minutes to reach home. No problem. You can
No
start the
problem, no
meeting and
problem.
continue.
So 5 to 10
Okay.
minutes, we will have an introduction, right?
Okay.
So we'll be
So
starting after 5 to 10 minutes.
okay.
Yes, sir.
Thank you. Thank you.
Nah.
Yes, Anjali, we can start now.
Good evening to all and one present here today. On behalf of AOP Gujarat, I welcome you all for today's Expert Connect series. This is our monthly webinar series conducted by AOP Gujarat, in which the common issues in office practice in pertaining to different subjects is discussed, and when to refer to the expert. That is what we're discussing. So today's episode 7 is in association with the Gujarat chapter of Allergy and Applied Immunology, which was recently officially installed on 3rd of August at Ahmedabad during the Allergy Conclave event that we had organized. So it's a newly formed chapter and we need everyone's blessings. This is the second program. The chairperson of Gujarat chapter is Dr. Kunal Shah, and the secretary is Dr. Rohit Agarwal. And Dr. Mitesh Kakkad has been instrumental in helping us form this chapter with the blessings of Dr. Neeraj Gupta sir. For today's episode, I would like to first welcome our president, AOP Gujarat President Dr. Jagdish Khamar Sahib, to give his welcome address.
Hello, good evening, friends. As a president of AOP Gujarat, I welcome all of you, seniors and colleagues, for one more episode of AOP webinar series, The Expert Connect, under the AOPG Presidential Action Plan. With changing scenario, the numbers of OPD patients coming with various another disorders, that is non-infectious disorders and non-infectious complaints, with some more patient with allergic disorder. And so that we learn about the issues of allergy in office practice. Our expert will guide us for next 50 to 60 minutes about how to handle and when to refer. I welcome with warm regards to President, Secretary and EBs and OBs of Central IAP. I also welcome Secretary and EBs and OBs of AOP Gujarat. My welcome to faculties of today's webinar, moderator and my friend Dr. Mitesh Kakkad, expert Dr. Krishna Mohan, and panelist Dr. Jigar Gandhi, Dr. Palak Shah, Dr. Parin Parmar, and Dr. Rohit Agarwal. With this, I welcome all of the connecting delegates for this webinar. Jai AOP, Jai Hind.
Thank you very much, sir, for your kind words. I would like now to welcome our Vice President West Zone, Dr. Ramesh Bajania, sir. He is present here to give say a few words.
Good evening, everyone. Thank you, Angelica Ben, for this opportunity. I wish all the best for this newly found chapter. In fact, it was a need of an hour. And Mitesh, as we know, have been doing wonderful job in the field of allergy and applied immunology. So under the leadership of Dr. Kunal, Dr. Rohit Agarwal, I am very sure that this chapter will thrive. And, we are looking forward to series of academic programs under the aegis of AOP Gujarat. We all know Dr. Jagdish and Dr. Samir Shah. They are doing wonderful job as far as vibrant academics and all other extracurricular activities are concerned. Happy to be part of AOP Gujarat. Jai AOP, Jai IIP. Thank you so much.
Thank you very much, sir. Now I'd like to welcome and introduce our expert for today. He is none other than Dr. Krishna Mohan, sir. He is a consultant pediatrician at Government Health Services Department, Kerala, and he is the immediate past national chairperson of IAP Allergy chapter. He is also ACVIP member 24-25. So welcome, sir. I'd like please say a few words for this program.
Thank you so much. At the outset, let me thank AOP Ahmedabad as well as the newly installed allergy team of Gujarat for giving me this wonderful opportunity, especially my dearest friend, Dr. Mitesh Kakkad, Dr. Parin Parmar. I think majority of people in this group are known to me and very close friends of mine, especially Dr. Parin Parmar. He was my batchmate in DA around 15 years back. I still remember him and Ramesh Bajania, sir. So thank you so much for the opportunity. Best wishes for the program.
Thank you. Thank you, sir. Now I'd like to request Secretary of AOP Gujarat, Dr. Samir Shah. This whole event, this webinar series is his brainchild. I request him to say a few words.
So dear friends, very good evening. And it's my pleasure that everybody of the different chapters is taking our own initiative, that is the Xpert Connect, in very positive way. And this is a seventh of that series, that starting from the my own chapter of the adolescent health, followed by the our different other chapters that will include the infectious disease chapter, urology chapter, NNF Gujarat, women's wing, and intensive care chapter. All the experts from the different chapter of the state, with that concept that we can at least get it together, come on a one platform, and make the our own state branches vibrant, that it ultimately give the our own known and unknown faculty who are really working hard in across the Gujarat can get the proper exposure in the Gujarat itself. And with that, we had clear-cut concept that our own 5 zone presence should be there during this panel discussion series. One moderator and 4 panelists from the 5 zone of the Gujarat. Of course, our outside Gujarat experts are really giving very excellent input, and today we again expecting same. And newly formed this allergy chapter and their enthusiasm, what we are seeing in the conclave that just they are completed with successfully at Ahmedabad, and now we are really looking for today's webinar also. So my heartiest congratulations to the allergy chapter that you can make this our AOP Gujarat more vibrant with this type of the different activity, and that is what we expect from the each and every to make them more active involvement in the AOP Gujarat activity in future. And that's all. And thanks again for all for joining today. Over to Dr. Anjali and Dr. G.
Thank you very much, sir. I would like to also acknowledge the presence of President-elect of AOP Gujarat, Dr. Jankna Sanghvi Madam, and all the other dignitaries who have joined us today. So now, without wasting much time, we proceed to the academic session, for which I'd like to request my co-host, Dr. Jigar Shah, to carry forward the proceedings.
Thank you, Angelika ma'am. Without wasting time, let's start the science. I invite all the faculties, Dr. Mitesh Kakkad as a moderator of this session. All the faculties are the expert in the field of allergy and applied immunology. Our panelists are Dr. Jigar Gandhi, he is practicing as a Patan. Dr. Palak Shah is my co-colleague and is a secretary of Academy of Pediatric Vadodara. Dr. Parin Parmar is practicing as Rajkot, and another is Dr. Rohit Agarwal, he is practicing at Surat. So let's start the session.
I'm Dr. Mitesh Kakkad. I would like to thank AOP Gujarat for giving this opportunity to the allergy chapter and this case series of allergy. And special thanks to Dr. Jagdish Bhai and Dr. Samir Bhai. So without wasting time, we'll start case series. We have taken 4 cases of routine day-to-day practice allergy. Slides visible? My slides visible?
Yes.
Yes.
Okay. Should I start?
Yes, sir.
So case 1. A 12-year-old male child complained of recurrent cough, dry cough early in the morning, associated with wheezing, breathlessness, and chest tightness in some episodes since last 7 years. He gets tired while playing and running in the school. So he has disturbed sleep and disturbed day-to-day routine activity also. Symptoms frequency increase in the last 1 year, and associated symptoms are runny nose, sneezing, nasal itching, almost daily, occurring 20 to 25 days since last 5 years. So on asking detailed history, he has taken multiple nebulization, LTRA, that is Montelukast, antihistaminic very frequently, courses of oral steroid also were given. Some relief occurs with nebulization, but again recurs almost frequency 20-25 days or a month. Many triggers were at home and in the school. Father is a smoker, has chronic cough and breathlessness, but he has not taken any treatment for that. The child weight is 45 kg, BMI is 22.34 per meter square, so he is overweight. So, Dr. Rohit, So after this history, how to approach this case?
Good evening, sir. In this case, 12-year-old child having symptoms, chronic conditions since last 7 years, and perennial symptoms every 20 to 25 days. Okay, so I would like to know about the triggers, which are perennial triggers, and which may be house dust mite, uh, molds, the cockroach, these are housed, even the cat. The house triggers allergens, pollens, which may be tree uh, pollen, weed pollen, or grass pollen. In this case, as the father is a chronic smoker, we would like to also know history of all the irritants. Possibly, first is smoking, the pollution. There could be incense sticks or dhoop, agarbatti in the house, or fumes which are available, room fresheners given, or air traffic, or any industrial gas or any other pollution with this irritant. The child also is having obesity, so we would like to know about other comorbidities, which may be allergic rhinitis, obstructive sleep apnea, obesity, GERD, or vocal cord dysfunctions.
So Dr. Rohit, you told about house dust mite. If we see the allergy cases, 70 to 80% of the allergy patient, we find house dust mite as a culprit allergen. So how will you elicit that history in, specific for house dust mite? What
If
will
we
you
want to
ask?
know about the house dust mite, we will need to ask them the history of carpets, curtains, pillows, what are available in the house. If there is an attic room, if there is a lot of books or soft toys, which may be a good source of a lot of house dust mites.
Okay, perfect. So Dr. Jigar,
Yes,
now
sir.
we have a history that almost suggestive of asthma, right? So, but
Yes,
before
sir.
stamping asthma, we need to rule out asthma mimics. So, what are the points you would like to tell about asthma mimics?
Good evening to all. So, in this case, this is a classical and wonderful case of allergic asthma. So again, as sir has already mentioned, history is very important for allergy disease. We have to ask detail about the mimics that we have to rule out before diagnosis of asthma. So we have to ask history related to failure to thrive. We have to ask and we have to rule out history of recurrent fever or any infection like pneumonia. Also, we have to ask related history for coughs and coughs contact. We have to ask history for vomiting and regurgitation to rule out GERD. We have to also ask history related to stridor or barking cough. We need to also inquire about and do also clinical examination related to unilateral wheeze or persistent monophasic wheeze. We have to also ask history and clinical examination related to chronic disease like cyanosis. We have to look for and ask for history suggestive of clubbing. Also, we have to inquire for chronic diarrhea also. So, by looking all these points, we can rule out asthma mimics.
Excellent. So, by asking this history, we usually rule out asthma mimics like GARD, foreign body, primary ciliary dyskinesia, cystic fibrosis, primary immunodeficiency. That is now also we are seeing in recurrent pneumonia, sinusitis, otitis media. And the most important history is if you are not getting response to your bronchodilator or nebulizer or steroid, then you have to think of this asthma mimics also. Very good. So on examination, this child had Denny Morgan fold. You can see below the lower eyelid, and allergic sinus are present. The dark circle below the lower eyelid region, and there is a transverse nasal crease. This crease is because of the continuous rubbing of the eyes, upward movement of the nose due to itching. So if we see the pre-bronchodilator peak flow meter we did was 170 liter per minute, and after giving salbutamol 15 minutes, the post-bronchodilator PFR was 230 liter per minute. So Dr. Palak, so having this history and rule out asthma mimics, what is your clinical diagnosis?
Thank you, sir. I am very thankful to AOPG Dr. Jagdish sir, Dr. Samir sir, and Jigin bhai for giving me this opportunity, and of course Dr. Mitesh bhai for conducting such a very good cases and for the awareness of the allergy. Now, as we have seen this case one, this is a classical case of uncontrolled allergic asthma. Why I'm telling uncontrolled? Because of the four important reasons. One, the daytime symptoms are very much. The second, the child is not able to sleep properly at night. Third, the child requires some reliever for the relief. Because of that, for if it is more than two, more than 3 to 4, then we can say it's uncontrolled asthma. And also, child is having, because of the the phase we have seen, it's a typical allergic rhinitis with a moderate to severe persistent type. Why it is a persistent? Why? Because it is more than 4 days for more than 4 weeks, and moderate to severe because there is a disturbance in the sleep, there is a disturbance in the activity, there is a disturbance in the day-to-day work also, and because of that we can say it is a moderate to severe persistent allergic rhinitis. And of course obesity as a comorbidity, which is playing a very important role in our case.
Excellent. So this child is also having asthma with moderate severe persistent allergic rhinitis according to the area classification. Excellent. So, Dr. Parin, do you think that we need any investigation for this case, or we can treat it clinically?
Okay. So, good evening, everyone, and thank you for giving me this opportunity. So now, clinical history so far has suggested that this is an allergic rhinitis with asthma. So the asthma is more likely to be allergic asthma. So it has two aspects to be evaluated. One thing is lung function, and second thing is the evaluation of immune system, that is the allergy evaluation. So as long as lung function is concerned, PFR has already shown post bronchodilator increase in PFR, which is suggestive of asthma. But it is to be remembered that PFR is usually used for monitoring and in remote resource limited settings. But as if we go through GINA guidelines, then it suggests that above 6 years of age, spirometry is the gold standard for diagnosis. And if whenever available, it has to be done. Second thing is, when spirometry is not possible due to age, then we can think of forced oscillation technique, that is FOT, which also helps to measure airway resistance and reactance. That is the lung evaluation, pulmonary function evaluation. The second part is allergy evaluation. Now, as child has allergic rhinitis and allergy asthma, so we are suspecting some aeroallergens which might be contributing to the allergy. And there is no history suggestive of food allergy. So mainly we will require to evaluate for aeroallergens, which are already mentioned already. So we will require skin prick test for allergy diagnosis.
For this case, we need to go for the spirometry and picrometer, right?
Yeah.
So here is the spirometry of that child. Here there are in spirometry we see two loops, flow volume loop and volume time loop. So here we can see that first we need to see the FEV1 by FVC ratio. Here it is pre-bronchodilation, it is 69 and FEV1 is 54, that is less than 80% of the predicted value. And after bronchodilation, FEV1 by FVC ratio increases and FEV1 increases by almost 13% from 54 to 61. So it suggests reversibility. So how to interpret spirometry? First, look at the FEV1 by FVC ratio. If it is less than 80%, 85, then see for the FVC. If FVC is normal, then it is suggestive of obstructive defect, right? So give bronchodilation, salbutamol 2 to 4 puff, and if it improves 12% or 200 ml, it is confirmation of asthma. But here, if ratio is low and FVC is low, that is possible in two cases. Either it is a chronic obstruction, chronic asthma, developing COPD, or it is going for the fixed airway obstruction. Now other part, if ratio is normal or above 85, see for the FVC. If FVC is low, then it is clear-cut restrictive disease. And if FVC is normal, then it is suggestive of normal spirometry. But here, one point to remember that normal spirometry does not rule out asthma, but it is very helpful. It is very sensitive test. So, as Dr. Parin said, in those patients who cannot do spirometry, because spirometry needs forceful maneuver. So, here is the option for lung oscillometry. It is very easy to do. we can do in tidal breath. Above 3 years of age, we can perform, even in elderly we can do, and it is very sensitive indicator of smaller airway obstruction. What are the parameters? We measure R5, total airway resistance, R5 minus R20, smaller airway resistance, R20, central airway resistance, and X5 and AX are the sensitive indicator for the smaller airway. So nowadays, for those patients or even who cannot perform spirometry, or some very elderly or very young child above 3 years, we can do lung oscillometry. So Dr. Rohit, after having this spirometry and this history, and after rule out asthma mimics, how will you prescribe the treatment for this patient?
Sir, for this case, we are dealing with two things, allergic rhinitis and asthma. So for allergic rhinitis, initially we will give inhaled nasal corticosteroids with antihistaminic, fluticasone plus azilastine nasal spray. One spray BD for 10 days can be given. Then we can shift to fluticasone furet, pure INS, two sprays at night for the next 6 weeks. And for the asthma, we can go with meter dose inhaler, budesonide first with formoterol, with spacer without mask as the child is 12 years old, and two puffs BD for 12 weeks. And one puff can be given whenever there is as a reliever, whenever there is an exacerbation.
So you told me that you want to use budesonide formoterol combination 2 puff. Number one, why 2 puff BD? And number two, why you don't want to use budesonide alone?
Okay. Sir, in this case, as the child is having daytime symptoms, also nighttime symptoms, low lung function, reduced activity. So this child is falling under the category of step 4 according to GINA guidelines. So I would like to give 400 micrograms BD, which would be the appropriate dose in this case of a 12-year-old child. And second, a MART therapy, maintenance and reliever together will be when there will be patient compliance, and second, exacerbation will be reduced to a great extent.
Excellent. So if patient is having normal lung function, then we can start on step 3, but lung functions are low, so we have to give double the dose of recommended for that particular age. So child is 12 years, so for these 12 years, low dose is 200. So we have to give double the dose. And fluticasone furet we can give about 2 years, and azilastine, it is an antihistaminic local spray, we can give about 6 years. Excellent. So can you explain the technique of INS, intranasal steroid, because that is very important part.
Yes, sir. Okay. First of all, we need to sit straight. Okay. Shake the bottle, see the expiry. We need to look down. And the method is to use right hand in the left nostril and left hand in the right nostril, and always to squirt in the lateral direction.
45 degrees.
Yes.
To avoid we have to avoid the septum. Excellent. So now to summarize the case, what is important in any asthma or chronic allergic rhinitis cases? Counseling is very important. We need to give at least 30 to 40 minutes for the new case. Assess every time, confirmation of diagnosis, identify the triggers, comorbidity, see the symptoms control, and according to that, you adjust the treatment. And again, when follow up, you review the response. This is Jina Chakra, assess, adjust, and review, right? So control of symptoms already discussed, that well controlled, partial control, or uncontrolled. Technique of INS is very important, that we have to explain as a doctor. You have to explain every time, because they might have steroid phobia later on. Explain how to take a spacer without mask, right? If patient is 2 to 4 years of age, spacer with mask. Above 4 years, there is no need of mask. And above 8 years, we have another option of breath actuated device, right? So address the trigger as already mentioned, house dust mite, pollen, fungus, cat, dog, allergen, other triggers like pollution, smoking, incense, diva, agarbatti, all comorbidities we have to address every time, and we need to treat also, right? Give peak flow monitoring chart. That is for the usefulness further to identify the trigger, and for to see the ICS response, and it is a home monitoring. You can give, it is very easy and very cheap method, and give a customer action plan for the symptoms and with the peak flow also. Follow up is very important in any asthma or allergic rhinitis case. First follow up should be at least after 4 weeks. See for the control of the symptoms, trigger, and inhaler technique and adherence, right? And after 3 months, we can go for the step down 25% to 50% according to the symptoms control and lung function. Now, very important thing is now we have till date we had from since last 5 to 7 years there is a therapy called sublingual immunotherapy. If child is sensitized to particular allergen with clinical correlation. If child is sensitized to house dust mite or pollen, we can go for the sublingual immunotherapy. That is the therapy that modify your disease. Okay. And for the severe step 4, 5, not getting good control, we can consider biologics like anti-Ig, anti-IL-4, anti-IL-5 biologics after the evaluation of phenotype and endotype. Excellent. So, Dr. Krishna Mohan sir,
Yeah, I'm here.
your
I'm here.
comment.
Yeah, so first and foremost, congratulations on a wonderful presentation, Dr. Mitesh ji and the panelists. I think you have covered everything in a very few minutes. You have covered everything in asthma. One thing which I would like to reiterate is that regarding the history, you have specifically told smoking history. So this case being a very poorly controlled asthma, that history is very important. So in our practical experience, what we have seen is that whatever thing you do in whichever drug you are using, including that biologicals, if you are giving, until and unless the parent is not stopping smoking, the symptoms won't improve. That is very, very important. So when we take the history, what they usually tell is that I don't smoke in front of my kids, but that is not enough because there is something called as third hand smoking. Third hand smoking means the tobacco particles getting attached to the dust material. So that is more than enough to be a trigger when the child is an asthmatic. So that is a very important point. Second point, which I would like to mention is that this is a poorly controlled asthma along with allergic rhinitis. So this child is on two drugs, that is inhaled steroids as well as intranasal steroids. So the one practical point that we have to note is that the total dose, that is the INS plus ICS, it should not cross the total recommended dose. So that thing also we have to take care. So very nice presentation. Thank you.
Thank you, sir. So we'll move to the case 2. So 1 year, 10-month-old female presented with history of recurrent cough, cold, difficulty in breathing since last 10 months. 4 to 5 episodes of dry cough, wheezing, accompanied by running nose, sneezing, nasal itch, watery eyes, every time associated with red rashes all over the body. Few of the episodes were associated with vomiting and 1 to 2 diarrhea. So if we see the past history, first hospitalization at the age of 12 months, she develops elevated rashes, runny nose, wheezing, watery red eyes within the 20 minutes of the consumption of the milk. Hospitalized for 3 days and treated with injectable medicine and nebulization. Again, 3 times admitted. First 14 months, she consumed milk product, diagnosed as a bronchiolitis. 19 months, again hospitalized, given nebulization, diagnosed as a pneumonia. Every time X-ray chest and blood reports were normal. Last episode at the 22 months of age was severe with severe breathlessness, wheezing, distress, needed oxygen and desaturation, and multiple nebulizations with oxygen was given. All episode had the involvement of skin, mucous membrane in the form of urticaria, hives, swelling of eyelid and lips. In between, few mild episodes occurred after the consumption of ice cream, curd. Within 10 to 30 minutes, she developed whole body urticaria, but well managed by oral cetirizine. Okay. So, Dr. Jigar bhai, what other history in this case you would like to ask?
Yes, sir. First, we have to ask onset of symptoms. Means time of onset of symptoms when taken milk, like 20 minutes, 2 hours, 4 hours, or 1 day, to rule out IG or non-IG mediated disease. Second, we have to ask whether it was boiled milk or raw milk. Third thing, we have to inquire about quantity of milk taken. Next, we can ask for Further, know about the weaning process. Weaning started when, which form of weaning started with which kind of milk, and when. Whether formula feed given just after birth or given direct breastfeeding. We have to ask history of atopy to the present scenario, like atopic dermatitis or seborrheic dermatitis or eczema or wheezing. We have to also inquire about the family history of atopy related, like atopic dermatitis, rhinitis or food allergy, etc.
Excellent. So by this history, you can identify either child is having IgE mediated or non-IgE mediated allergy. IgE mediated within minutes to hours, 2 to 3 hours, child will have symptoms, and it will involve system, respiratory, GI, as well as cardiac and skin and mucous membrane. While in non-IgE mediated, you will have mainly limited to the GI symptoms. So very important history you can identify. So, Dr. Palak sir, how will you approach for the diagnosis?
Now, it is very important to know that for any cases of allergy, the most important part is the history. So, whenever we see any patient with an allergy, maximum time, I think more than 50-60% of your time, you just have to give for the history, because proper history points out towards the maximum cases of diagnosis. Now, after proper history, we will prefer, as the history suggests you, that specifically after the milk and milk product, the child has developed the reaction. So in such a cases, it is always better to find out the culprit. So we will go for a skin prick test, which is a very simple test, which you can do on OPD basis also. In our case, we have done a skin prick test, which the positive control, the histamine is 3 mm positive, whereas Blumia tropicalis is 4 mm positive, the storage mind, whereas milk is 7 mm positive. So whenever a skin prick test, it is a positive, it is always advisable to go for a specific IG by immunocap method. It is a very simple method by which you can find out that what is the exalt value. So normal value is less than 0.1. In our case, it's a case in which is 20.3. So it is significantly high. Also in our case, with the help of a single plex, we are able to also diagnose which protein it is. That is a BOSD8. Why the protein is important? Because on the basis of this, we come to know that it is a heat stable or a heat labile protein. So if a patient is having, heat stable protein, then even after boiling also, we cannot give a milk. Where if it is a heat labile, then just with the help of a boiling, if we boil or if we give a bakery item, then the child might be able to tolerate properly. So I want to summarize that a history, allergy test in the form of a skin prick test and a blood test in the form of a specific IG, which with the help of which we are able to diagnose exactly what the culprit is of this anaphylaxis.
Excellent. So if here's SPT is 7 mm with pseudopodide, that is very important. That suggests high clinical reactivity. And for this age, 7 mm is high. And so positive predictive value for this sensitization to milk is very high. So the diagnosis is clear, anaphylaxis in case of cow milk protein allergy. So Dr. Parin, define the anaphylaxis and what are the common symptoms and causes of the anaphylaxis.
So anaphylaxis is the most serious manifestation of allergy, right? So it is defined as a serious systemic hypersensitive reaction. And most important thing is it is rapid in onset and rapid in progression. And it has the potential to compromise airway, breathing, circulation, and at times death. Now, it is very important to remember that there is the definition, another definition, which suggests that there should be multi-organ involvement in case of anaphylaxis, and usually skin and mucous membrane systems, gastrointestinal symptoms, respiratory symptoms, and cardiovascular systems are involved in children. But in many of the cases in children, the typical anaphylactic shock may not be seen. So CVS involvement may not be there. Even if skin, GI, and respiratory symptoms are there, we have to diagnose anaphylaxis. There is one World Allergy Organization recent definition that also suggests that in cases where there is acute laryngoedema or acute severe bronchospasm or acute severe hypotension, the only symptom, and there is exposure to potential allergen or a known allergen for the patient, then even in absence of other symptoms, we can diagnose anaphylaxis. So as we mentioned that it is a multi-organ, multi-system disease, so we can have several presentations. So common skin and mucous membrane symptoms like hives, angioedema, itching, generalized, they are present. Respiratory symptoms like it can be upper respiratory or lower respiratory symptoms in the form of sneezing, rhinorrhea, wheezing, coughing, breathlessness, bronchospasm, they are present. Gastrointestinal symptoms like vomiting, diarrhea, and crampy abdominal pain, they can be present. And cardiovascular symptoms like those due to hypotension, syncope, pre-syncope, delirium, feeling of impending doom, loss of consciousness, collapse, tachycardia, they can be present. Now, as long as cause of the anaphylaxis is concerned, in children, food allergy is a very common cause, and common foods that are known to produce anaphylaxis in our setup in India, they include like milk, wheat, even chickpea is very common, egg, shellfish, and nuts and tree nuts. So peanut, soy, and tree nuts. So these are the common food allergens. Several drugs are more likely to cause anaphylaxis, which include penicillins and cephalosporins. So in short, beta-lactams. Also NSAID like ibuprofen and radio contrast media exposure. And now biologics are increasingly used in practice. So they are also known to produce anaphylaxis. Insect sting like honeybee sting is known to cause anaphylaxis. And we have to remember that there are some non-immunological mechanisms which are also known to cause anaphylaxis, like exercise, cold, those are physiological factors are there. And in some cases, anaphylaxis remains idiopathic. So cause is not known, but still anaphylaxis can occur.
So in pediatric, we give lots of vaccine day by day, right? Day and day.
Huh?
So it is also
Yeah, Jain
one
aaya
of the,
ho.
but one can, vaccine also is a one of the drugs that can cause anaphylaxis. So we need to be prepared for the action plan, right?
Yeah.
So Dr. Rohit, now diagnosis is clear. Patient had severe anaphylaxis. Last episode was with desaturation and oxygenation. So now you are discharging the patient and you want to give advice for the future prevention of attacks and want to give action plan. So what will be the advice?
Good evening, sir. Sir, this is a case of anaphylaxis in a cow's milk protein allergy. Okay, so here we need to give anaphylaxis action plan
नहीं बेटा ठीक
in
हो
which
जाए
there will
अभी
be
तो बताए
pre-filled
तुम बहुत
adrenaline
बड़ी
injection.
डॉक्टर हो गए
Sorry. Uh, Here we need to give pre-filled adrenaline injection in a spectacular box given with training of how to use this injection to the parents, the IM use. Second, avoidance of the trigger, which is in this case is the milk. And as the trigger was heat stable, so even the heated milk, even any milkshake or even tea or any form of milk has to be avoided to the kid. When as we are avoiding the milk, oral supplementations of calcium and vitamin D in the diet plan should be given. And we need to repeat the trigger allergen after 1 year.
Correct. So when you are giving pre-filled adrenaline injection, we need to prepare, right? So how we prepare? Because we all know that pre-filled adrenaline is not available. It is available in the gray market and it will last for only 3 months. And the cost is around 14 to 16,000 rupees. And so for that option, what we can do is take a 1 cc of BD syringe that we are using for the BCG. Remove the 26 number needle, attach 25 number needle that we can use for the intramuscular injection, and loaded adrenaline should be given to the patient with in the spectacle box. Why in the black dark spectacle box? Because adrenaline is a light sensitive, so it will be decolored by the exposure to the light. So in the spectacle box, for that we need to give and advise patient how to use it. Excellent. So, Dr. Rohit, explain anaphylaxis action plan in very short.
Okay, sir. So this is a very good slide for the anaphylaxis action plan. First of all, we need to identify the patient, their age, their number. We need to identify what are the triggers. We need to write them down. We need to educate the parents what are the signs and symptoms, how to early recognize the condition, and how to give the adrenaline. The position is very important. It should be given in the anterolateral aspect of the thigh. First of all, need to check for airway, breathing, circulation. Enough adrenaline should be prepared and given intramuscular. So the dose is 0.01 mg per kg of 1 is to 1000. So we need to give them the quantity. So 1 to 5 years, it can be 0.15 ml, 6 to 12 years, 0.3 ml, and more than 12 years, 0.5 ml. It can be repeated every 5 minutes for 2 doses. Then we need to give the supportive treatment of salbutamol nebulization, glucocorticoids, and antihistaminic. Hospitalization should be done for the first 24 hours. And we need to see if there is any ICU management, if there is any refractive anaphylaxis.
So the drug of choice is adrenaline, adrenaline, and adrenaline, intramuscular lateral aspect of thigh, before Avil, before hydrocortisone, before Dexona. So the take home for the anaphylaxis is first identify, recognize fast because otherwise you may lose the child, right? And elevate the extremities and supine position and adrenaline, adrenaline, adrenaline. Even if you give adrenaline and you just suspect anaphylaxis, even it is not anaphylaxis, it will not harm. So the take home message for anaphylaxis adrenaline, adrenaline, and adrenaline. Excellent. Dr. Krishna Mohan, sir,
Yeah.
your
So
expert opinion.
you have covered the topic very well. So as you said, adrenaline usage should not be, you should never forget using adrenaline. So any acute condition, severe condition, following intake of the food, 1 DD is definitely anaphylaxis. And as you already mentioned, if it is occurring after some time, if it is a delayed reaction, you have to remember the non-IG mediated reactions also. One important entity among that is the FPIS. FPIS is food protein induced enterocolitis syndrome, where it is a non-IG mediated syndrome where the child will be presenting in a very severe and sick in manner, and the child will be presenting in shock. So this child will be having recurrent vomiting and loose stools, and he may be presenting in shock. And many a times we will misdiagnose this case as sepsis and mismanage the patient. So what we need to give an IV fluid. So this entity also we have to remember FPI. So anaphylaxis and FPIs are two very important fatal reactions which we have to remember in connections with food allergy. So you have covered every point. So as Dr. Mitesh mentioned, unfortunately, we still do not have the auto injector. So the basic difference between an auto injector and the pre-prepared adrenaline, as Dr. Mitesh mentioned, is that the other one, that is the EpiPen, is an auto injector. The normal syringe, it needs somebody else too, because when you are a patient and if you want to give that take that injection yourself, if you are in a state of anaphylaxis, you may not be able to do that, but an auto injector can help. So we will do that. I think through the chapter itself, anaphylaxis awareness has been done. You are having a series of lectures was done last month on this topic alone, thanks to Dr. Neeraj Gupta. I think soon some step will be taken regarding the availability of auto injector like EpiPen in India also. So thank you so much, Dr. Mitesh and team, for bringing this very useful topic.
Thank you, sir. Thank you, sir.
Ramesh
So
Bajania,
we'll move to the case.
Yes, sir. In fact, regarding this adrenaline only, I wanted to share this thing. Indian Institute of Science, two scientists and led by Dr. Parmar, sir, they have developed a injectable adrenaline, and that will cost hardly 500 rupees. So, because himself, Dr. Parmar, sir, had two severe anaphylactic incidences after food. And as Dr. Krishna said, it is very correct because the one who suffers from anaphylaxis hardly he gets time. I mean, it is within 15 to 20 seconds, generally the effect starts after consuming the food. So Dr. Parmar showed me that he keeps this pre-filled syringe in his upper pocket only. And he demonstrated also to me when we are sitting that it was like this. And immediately he simply like as if he stepped. So auto injector would definitely, I mean, is a great thing. But looking to the cost and now, because only the imported one is available, I think what Dr. Parmeswar told me, 30 to 40,000 rupees one shot. So this would be a great boon. So you can be in touch with Dr. Parmeswar, this chapter obese. And I think
I think
now
it will take
within
1 or
short time they are
2 years, right,
marketing.
sir?
No. Within short time they are marketing. Within short time.
Okay.
So that's what I wanted to share. Thank you so much.
Thank you. Thank you.
We will take
So
question answer at the end.
yes. So we'll move on to the case 3. So 4 years old female child presented with history of elevated red rashes with intense itching all over the abdomen and legs since 2 days. It was occurring and disappearing. Fever since 2 days with runny nose, dry cough and body ache. On asking history, there is no specific food history, no insect bite, no medication, no any specific NSAID or other antibiotics or given, no history of previous similar complaint. So it is a clear case of acute urticaria. So Dr. Palak, can you define what is urticaria and what are the common causes?
Now, the third case is very interesting case. Why? Because such cases we usually see in our routine OPDs. Being a pediatrician, being an allergist, both we deal with it. So it is better to understand in a depth about this acute urticaria. So basically, urticaria is a skin condition characterized by development of the wheals or a hives. It can be associated with the angioedema or it cannot be also associated with angioedema. And the characteristic of the wheels is that it is very circumscribed and with the elevated margins. Important point to be noted is that the itching is there. In 20%, the itching might be less also. And also, most important, the skin returns to its normal appearance usually within the 24 hours. And second, regarding the causes, acute urticaria, most common cause is because of some infection in a form of a virus or a bacteria or a parasitic infection. Like if a child might be suffering from some cough or cold or a loose motion or any infection in the dental or some urinary tract infection. Second most common reason is the food. Common 7 food which we encounter in the Indian are basically starting with the milk. Second most common is a wheat. Third it is because of egg. Fourth it is because of the fish. Fifth because of the different nuts. And also because of the additives and also the different color additives used in the food causing the pseudo allergies. The third most common it is because of the drugs. The common drugs which causes acute urticaria are the NSAID. Usually we use for the fever also there is a ibuprofen. Second are because of the cephalosporin groups also, and quinolones also causes. These are the common ones. Fourth most common reason is the insect bite. It can be because of some mosquito bite, or it can also be because of the honeybee bite also. And usually, in spite of trying to find out the reason, in many cases it is idiopathic. We couldn't find the reason.
So as Dr. Palak mentioned, we need to diagnose acute urticaria by 15 to 20 minutes history. And what is the management? The no need of any investigation for acute urticaria. But if it is recurrent and if you are suspecting any food allergen or drug or any arrow allergen, then only there is a role of investigation and treatment of the cause, either viral infection, UTI, dental. You treat the cause, urticaria will be gone. Then for the treatment, second generation, not first generation, second generation oral H1 antihistaminic for 7 to 10 days. That is enough. So, Dr. Parin, we have talked about this acute urticaria. So, how will you classify urticaria and give some elaborate some form of chronic urticaria?
Yes, so for clinical purpose, we classify urticaria into acute urticaria and chronic urticaria. And the important distinguishing criteria is the duration criteria. So if the duration of urticaria is less than 6 weeks, then it is acute urticaria. And if duration is more than 6 weeks, then we'll call it chronic urticaria. Now, it is very important to distinguish between the two because right, starting from etiology to pathophysiology to treatment, everything is significantly different in both the cases. So as acute urticaria has already been discussed, we'll move to chronic urticaria. Now, chronic urticaria is again subclassified into two types: chronic inducible urticaria and chronic spontaneous urticaria. So CIU and CSU. When there is a known inducing trigger for urticaria, that will be chronic inducible urticaria. Now that based on the inducing trigger, they are classified as cholinergic urticaria, solar urticaria, heat urticaria, cold urticaria, even symptomatic dermographism, aquagenic urticaria, delayed pressure urticaria, or vibratory urticaria. So depending on the inducing factors that trigger urticaria, that will be chronic inducible urticaria. The second part, that is second subtype of chronic urticaria, is chronic spontaneous urticaria. Now, as the name suggests, it is spontaneous. So there is no known inducing factors, but CSU will have some comorbidities and some aggravating factors. So the most common comorbidity of chronic spontaneous urticaria is autoimmunity. So that is the comorbidity. And they can have some factors which trigger the episodes of urticaria or aggravate urticaria, like fever, exposure to heat, or sudden temperature changes, or exercise, or in females during menstruation times, or the periods of emotional stress, or alcohol, or likewise. So we have to identify those triggers, although the patient has chronic spontaneous urticaria. And CSU is largely idiopathic. So exact cause of CSU is not known.
We know that chronic urticaria has no cause in almost 70 to 80% of the patients. So you have to ask history for the triggers. So here triggers are very important. And Dr. Parin said the autoimmune urticaria. So what will happen? There will be auto antibody, IgG antibody against IgE and against FCR epsilon receptor also. So there are two types, type 1 and type 2. So Dr. Rohit, uh, we have diagnosed chronic urticaria. How will manage in our day-to-day practice?
Sir, in the management of chronic urticaria, as it is mostly idiopathic, we need to do the symptom control, normalize the quality of life, as Dr. Parin sir has mentioned, to minimize the triggers. Then there is pharmacotherapy, second generation antihistaminic, as you mentioned. So there can be levocetirizine or fexofenadine, which can be used for 2 to 4 weeks. If still there is an inadequate control, then we can increase the dose of antihistaminics every 2 weeks up to 4 times. If there is still an inadequate control, then we can add on the biologicals like anti-IgE, omalizumab in this case.
So in 20 to 30%, even after increasing 4 times of H1 newer generation, second generation H1 antihistamine, you will not have result. So you have to go for the anti-IgE, that is omalizumab. And we have another option of omalizumab because omalizumab is little bit costly, 13,000 injection we have to give monthly. So we have another option of cyclosporine, but cyclosporine is a very some toxic drug. So we need to monitor kidney function and blood pressure. So better if patient is affording, we would go for the omalizumab if not responding in 4 to 8 weeks of 4 times antihistaminics. Excellent. Krishna Mohan sir.
Yeah. So you have covered everything. So the only thing is that as far as a practicing allergy specialist is concerned, this is one of the most difficult cases to manage. So every time we start some medicine, they will get some temporary relief, but they will be coming back. And they will be asking how long will these symptoms will last. So we have to tell the patient that it will take some time. That is, the counseling is very, very important in this, especially in chronic urticaria. It will take time. So what is usually seen is that around 50% of patients will improve or will become normal in around 6 months' time. Another 20% will take around 3 years, and further 20% will take around even 5 years. But we have to remember there is still a last 10% in whom the symptoms may persist more than 10 years. So these are the most difficult cases where we have to try many of the medications, including omalizumab, cyclosporin, and all. But even after starting that, the patient may not be getting good control. But you have to remember, even in these patients, spontaneous remission can occur anytime. So it is a long-term business. It is not like a very acute disease. You have to counsel them very properly that this disease will take time. Otherwise, this patient will go to some other person. And another very practical point, as Dr. Rohit was telling, you have to double the dose, quadruple the dose. That is very simple to say, but as far as the patient is concerned, until and unless we counsel them properly with the EACI algorithm that this is, we are quadrupling the dose, this patient will go to some pharmacy and the pharmacy man will make a comment. This is not a pediatric dose. This is more than the adult dose. So we have to be very careful when we are prescribing the double dose as well as the quadruple dose. We have to tell them properly. So practically in my clinic, what I do is that I use the printout of the EACI chart and show them that we are at this stage and we need to double the dose of the antihistamine now. So that is all.
Thank you, sir. Thank you. So we'll move on to the last case, case number 4. We'll go a little fast as we are short of time. 8-month female child presented with complaint of red scaly lesion over abdomen, back since 15 to 20 days. Redness around neck and cubital fossa. Child remains irritable, cranky with disturbed sleep during episode. At the age of 2 months, first time lesion started over the cheeks. Parents worried for the rashes and allergy, consulted many doctors and had taken antihistaminic lotion, ointment every time. But after getting some relief, again occurring every month. So child is on breastfed and formula fed since birth. So Dr. Parin, what other history you would like to ask?
Okay, so first and foremost, we have to ask that exact age of onset of the symptoms. So at what age the rashes started, and which were all the sites involved during all the episodes, because it is possible that in previous episodes some other site may have been involved. Then pruritus is a cardinal symptom of atopic dermatitis, so we have to ask whether itches or not. And what were all the treatment given? What were all the topical as well as oral treatments given to the patient? And what practically happens is that when patient comes with atopic dermatitis, the parents' focus is usually on atopic dermatitis. Then they don't mention that at some other time, some other vomiting or diarrhea or something, gastrointestinal symptoms or wheezing had occurred. So we need to ask, even if patient is presented with atopic dermatitis, that whether he had any respiratory symptoms recurrent or recurrent GI symptoms in the past. So that is about the past history of atopy. And we have to also ask family history, whether any family member has any atopic disorder. So we have to remember that when we are thinking of allergy, it is possible that a child has atopic dermatitis, father may have asthma, and mother have allergic rhinitis. So it's not necessary that it is the same disorder which is inherited. So that's about family history. The second thing is atopic dermatitis is a disorder where allergens as well as non-allergic irritants, they also play a part in the pathogenesis. So we have to ask about irritants like soaps, detergents, and all the possible cosmetics, soap, shampoos, creams, moisturize, whatever patient is using, and the clothes or the linen of the bed sheet, all those things. And some fabrics like nylon, synthetic fabrics, or woolen fabrics, or tight clothing, they are known aggravators or non-allergen triggers of atopic dermatitis. So we have to ask that. As long as allergy is concerned, we have to ask aeroallergens, food allergens that we have been already discussing. What are those possible allergens, contact allergens, which can trigger the atopic dermatitis episode? And also, it is important to remember that at times, skin infections, especially Staphylococcus aureus infection, can aggravate or cause exacerbation of atopic dermatitis. And extreme weather changes, like one day it was sunny and next day there was suddenly cloudy and it starts raining, So those kind of extreme sudden weather changes, they can also trigger one episode of atopic dermatitis. So when the triggers are known, we can suggest them avoidance of triggers.
Excellent, Dr. Parin. So here what happens, the filaggrin barrier is gene defect is there. So there is a loss of skin barrier and it will exposure of the virus, bacteria and allergen and irritants. So that will decide and on the genetic predisposition, what will happen either Th2 or Th1. So there are interleukins involved IL4, IL5, IL13 in Th2 pathways and IL17, IL22, IL31, IL25, 33. These are the interleukins that are responsible for the Th1 pathway. So, Dr. Jigar, so this is classical case of atopic dermatitis. So, classify atopic dermatitis and what is atopic dermatitis?
So, sir, atopic dermatitis is a chronic relapsing inflammatory condition. It is extremely pruritic inflammatory skin disease that tends to run a chronic and relapsing course. So, in classification, it is very difficult to elaborate in a very small time. So, I will give a very brief classification. So, based on clinical classification, acute, subacute, and chronic. In acute atopic dermatitis, red, papule, edematous, and weeping like lesions. In subacute, red, scaly, and exoriated plaques, and in chronic, thickened, lichenified plaque and fibroptic like papules. In practical classification, we can classify according like mild, moderate, and severe. In mild atopic dermatitis, dry skin, minimal itching, and some redness present. In moderate atopic dermatitis, dry skin with frequent itching with redness. In severe, we can see widespread areas of dry skin and persistent itching with severe redness. Also, we can classify according to Scora's staging. Also, we can classify according to the site and area where atopic dermatitis is present. Also, we can classify it according to the infantile and childhood presentation.
Excellent. So, three important parameters we need to remember. One is the morphology of lesion. Number two, intense itching and area involved. So, grossly, we can see this is mild, moderate, and severe. So, if we, as already Dr. Jigar said, that see, first picture suggestive of acute lesions, red, VP, edematous lesions. There are oozing also on the cheeks. Now, second is subacute. The lesion has become erythematous but scaly, dry, flattened, and there are scarring. And what is chronic? Lichenification, thickening of the skin, fibrotic nodule, that is called prurigo. That the round papule you can see on the last picture, that is a prurigo. So age-wise distribution, infancy, we all know that in infant we see on the face, cheeks and extensor, childhood flexor, antecubital fossa, popliteal, hand, feet and neck. As child become older, adolescent and adult, any feet, hand, neck, nipple eczema, flexors and eyelid also we see isolated atopic dermatitis. So age-wise, age-dependent distribution is also important for the pediatricians. So Dr. Palak, this is mostly a clinical diagnosis, but there are two mechanisms involved, Th1 and Th2, Ig mediated and delayed hypersensitivity, right? So when you will go for the investigation in atopic dermatitis, what is the role of SPT or specific Ig by immunocap, or when will you go for the CRD, or what is the role of elimination diet?
Yes, firstly, I would like to congratulate Dr. Mitesh sir for selecting very specific cases which we'll routinely see in our OPD as a pediatrician also. So now talking about this atopic dermatitis case, see actually atopic dermatitis it can be IgE mediated, non-IgE mediated also. Now in case of IgE mediator, when you are suspecting some specific allergen, like say in a second case where cow milk protein was suspected, in such cases a skin prick test has a specific role, and after doing a skin prick test we can go for a specific Ig by immunocap to find out that exactly which protein is basically involved. And for a known Ig mediator or say a delay diet, we usually prefer to go for a patch test. Now in the case of atopic dermatitis, to find known IG or delay type is very difficult and almost next to impossible. And if you are suspecting multiple triggers or multiple allergens, then in such a cases CID is also preferable. And CID usually we do when a patient is not able to unable to stop the antihistamine, or the skin is only not there where we can do a skin prick test, or if a patient is very much worried or very much frightened about the prick. Such a cases, a CID is a preferable one, by which we can also diagnose the actually what protein is basically involved.
Excellent, doctor. So SPT has a very specific role. If you are suspecting food or aero allergen that causes triggering of the atopic dermatitis, then go for only SPT and specific IG by immunocap. And if patient is polysensitized, parents give history that child is having allergic rhinitis, asthma, atopic dermatitis, all type of allergy, then you can think of CRD in very limited cases. So last, Dr. Rohit, after the diagnosis of atopic dermatitis, mild, moderate, or severe, whatever the atopic dermatitis is, how will you manage? What advice will you give to the parents?
Thank you, sir. In a case of atopic dermatitis, management first is to do the avoidance trigger, to know the allergens and to avoid them. Second is the bathing technique. So we need to counsel them. The bathing has to be 5 to 7 minutes in the warm water, and uh, after the bathing, immediately in 1 to 2 minutes, you need to use the moisturizers. Also, we can use the wet wrap therapy, like the rolling of the skin with the wet cloth after applying the moisturizer. Then the emollients should be fragrance free, and we can use the topical corticosteroids, low means mometasone or desonide, or some mild to high potency like fluticasone, propionate. So how do we use this? Is by a fingertip unit. So what is a fingertip unit? Is from your tip of the finger to the distal phalanx is your one fingertip unit. And how do you measure? So this one FTU can cover your one crossed hands. So the full hand, two hands can be measured or can be given as a one FTU. And also we can use topical calcineurins like tacrolimus can also be used in few of the cases where we want to go and do steroid sparing situations.
Excellent. So I would like to add in emollient. That emollient should be cost effective. If you are dealing with mild cases, then use petroleum jelly or liquid paraffin will be enough. But if you are dealing with the moderate severe persistent cases, then adding of ceramide, fatty acid, cholesterol will be helpful. But these moisturizers are little bit double the cost of the routine moisturizer. So you should not use for all patient any moisturizer. We should consider the cost and fragrance and other content also. And second thing, when you are dealing with the face eczema or finger or genital, use very low potent steroid like desonide and hydrocortisone, or you have option of calcineurin inhibitor. And calcineurin inhibitor is a classical drug for the steroid sparing. As Dr. Krishna Mohan said, that if child is having allergic rhinitis, atopic dermatitis, allergic asthma, you are giving lots of steroid. The steroid is the only treatment. There is a role of calcineurin inhibitor. You can spare your steroid in skin condition by applying calcineurin inhibitor. You can use about 2 years. It is very safe, and the only side effect is little bit of burning. So tacrolimus very easily available. 0.03 ointment cream. It is available. Pimecrolimus also available. So for moderate severe, if you want to use long term medicine, then this is the choice. There are other phosphodiesterase inhibitor, crisaborole, JAK inhibitor are now available in the market, but we usually treat up to moderate to severe by this only medication. So now I would like to end this session. Thanks to all the speakers and faculties and AOP Gujarat Secretary President and all the viewers. So would like to take question if there are in the boxes. Dr. Krishnamon sir, your comment for atopic dermatitis, sir.
Yeah. So wonderful presentation, sir. So only comment is that some, as you told, the some practical points. So those people who cannot afford, there is a practice, especially among general practitioners, that instead of moistures, they will advise oils. So coconut oil can be used, but we should always remember the olive oil, mustard oil, etc. They are act as irritants and they should not be used. They will aggravate the case. That is a very important point. But coconut oil, especially the virgin coconut oil, can be used in mild to moderate cases, not in very severe cases. There we have to go to the commercially available moisturizers only. And the second point which I would like to add is regarding the steroids. So the different tables that we see in the textbooks regarding the potency of steroids itself is confusing. So especially among general practitioners, what they do is that they will be using, as Dr. Mitesh said, they will be using a very high potent steroid for the face and all. So for pediatrics, you just have to remember age-wise, in infants, you have to remember only two drugs, hydrocortisone and desonide, which can be used. And beyond infancy, you can use hydrocortisone, desonide, and mometasone. So three or four drugs only you need to remember, and that will be enough.
So, thank you, Krishna Mohan sir, for giving your time and your expert comments, as you are the
Thank you
king
so
of
much.
this field.
Thank you so much, sir, Dr. Mitesh. That's a wonderful presentation.
Thank you, Mitesh bhai, for
Thank you.
perfect selection of cases and lucid presentation, and not panelists for precise answer. Before ending, I have also some question. Can anyone give some idea about recent changes in GINA guidelines? Because we usually, as a common pediatrician, use budesonide as a preventer and asthalin or salbutamol as a reliever. But in recent your slide, you have included fluticasone fumarate plus a long-acting beta agonist.
Lava.
LABA.
Mitesh, stop your screen, please. I did, sir. So you can continue.
Done?
Mitesh, you can continue the answer. I just completed that.
So your question is about GINA changes 2025 or from 20? So latest GINA changes in the under 5 visa, what they have removed is probability of asthma, right? Only three parameters you have to remember. Number one, past history of visa. Okay, two wheezing episode in the past year. Current episode of wheezing responded to within minutes to your steroid or salbutamol, that is your SABA. And third thing is rule out asthma mix that we have already discussed. Now GINA has given only three important parameters. In between symptoms, everything is there, but they have removed the probability of asthma in GINA 2025. And the another thing is they have removed the magnesium sulfate nebulization in acute asthma flare-up. And above 4 years, we can use formoterol and budesonide combination, that is MAT therapy. And last change is tiotropium, that is LAMA. They have also included in above 4 years of age. So previously, last year, it was not there in the GINA tiotropium and this use of LABA and ICS. Otherwise, everything is same.
Duration of antihistamine in acute urticaria?
7 to 10 days.
7 to 10 days.
Role of steroid in acute urticaria?
In acute urticaria, there is no role of steroid, but there is some role of steroid in chronic urticaria. If patient quality of life is not, then there is severe exacerbation by some triggers. You can use very low dose with 0.5 to 1 milligram per kg for 3 to 5 days. That is enough. No long-term use of oral steroid in any urticaria. You need to treat the cause. You identify the cause, but if you want to give good quality of life for 1 to 2 days, then you can use for 3 to 5 days. But if you are dealing with viral infection, any infection, you cannot use for acute urticaria.
Kunal bhai has many questions. Kunal bhai.
Sir, I wanted to know what is the logic behind using intranasal steroid for first 10 days different and after 10 days different?
So in that case, if we see the history, patient is suffering from allergic rhinitis, sneezing, itching, watery nose, blocked nose since years. So first of all, we want to give some relief for that patient. And here the drug of choice is intranasal steroid, right? So if you give some relief, then patient compliance will be more. If you are giving relief in 5 to 7 days, patient will be little bit symptom free, good quality of life, good sleep. So that's why we want to give intranasal and azilastine antihistaminic with steroid. And you have to give steroid for at least 6 weeks to 12 weeks. So you can start with azilastine intranasal steroid combination. Alone azilastine is not available. So use for only 7 to 10 days. That's it. And switch over to intranasal steroids.
If we use long-term acylastine, is there any issues?
You cannot use because it is a short acting drug, right? Why you want to give the drug of choice for blocker and sneeze runner? It is always a intranasal steroid. You have to treat chronic inflammation, eosinophil, mast cell, basophil, cytokines. They won't be covered by antihistaminics. It will act only on histamine receptor. That's it.
Okay.
So just give relief with histamine, itching, sneezing, and switch over to intranasal steroid.
Okay, sir. And one more question.
Just 1 second, Mitesh bhai. Instead of azilastine, can we give an oral antihistaminic along with the intranasal steroid for short term as a reliever?
We can use, but it is only for mild intermittent. There, where you don't want to use intranasal steroid, right? So that you can give antihistaminic orally. Why here intranasal antihistaminic with steroid? Because you will tell patient that he will be accustomed to your intranasal spray, right? And the
No,
local
my
antihistaminic
question
will act faster. It will
Yeah,
act
my
faster.
question was instead of adding azilastine with the nasal spray, can we give the oral? We are continuing with the INS, but along with to give a relief for the first 1 week, can we add an oral Allegra along with the intranasal spray
Even
instead
your
of giving
oral
the combination?
even oral fexofenadine will not give immediate result. It will take some time. So here it will act within 15 minutes. So patient will get relief. Suppose patient want to go for exam and you want to reduce the symptoms, sneezing, itching, right? So you can use intranasal antihistamine.
Okay, sir. One more question: Is it compulsion to do a spirometry for all cases of asthma?
The GINA has suggested you have to treat asthma. You cannot treat asthma without spirometry because spirometry is nowadays available everywhere in most of the cities. But the inferior option you can use is spectrometer. You cannot treat asthma by GINA without spirometry or lung oscillometry even.
Okay, sir. Is skin prick test necessary in asthma?
If you are suspecting HDM and aeroallergen sensitization, yes, it is necessary or associated with comorbidities like allergic rhinitis or other things.
Sir, one more question. If a child is improved, if a child of asthma is improved, but he has wet cough episode even after 2 months of DPI, should we rethink any diagnosis?
You revisit your diagnosis every time. You have to confirm your diagnosis again. You ask patient to come for the follow-up. Wet cough usually is not an asthma. The asthma cough will be always 90 to 95% will be dry. So you are dealing with either upper airways or syndrome or protected bacterial bronchitis.
You have to consider TB.
Okay, sir. Or one more question on atopic dermatitis. If there is severe peeling of whole body, itching, and history of similar in elderly sibling, which has now subsided after 10, 12 years of elder sibling. Now he is normalized. They have a second child who has similar episode in the infancy. So what is the this is a genetic probability of the having in both the siblings?
Yes, there is a genetic filaggrin gene defect there is a role of genetic defect filaggrin expression gene. In some patient there will be a less expression, some it will be a more. So there is always genetic expression of filaggrin defect, and you have to prevent atopic dermatitis by treating because this is the first thing of atopic march. And what is atopic march? After atopic dermatitis, the chances of allergic rhinitis and asthma for that patient is 6 times more in his or her childhood. So you have to treat atopic dermatitis vigorously, identify trigger, identify your allergen, and you shoot hard.
Can I add on point, sir? Mitesh, sir? Yeah.
Yes.
So, as the case that you mentioned, that is severe atopic dermatitis in one sibling and other sibling also having severe thing. There, you have to think about primary immunodeficiency also, and this is sometimes severe atopic dermatitis. It can be due to a job syndrome, hyper IgE syndrome or even Viscot Aldrich syndrome can present with atopic dermatitis. Many cases because they will be coming to the allergist, but there will be a primary immune defense. So we have to think about that also.
And sir, take the care of moisturizer, skin care, what else we can add on to the child?
Avoidance of triggers.
Sir,
And if you are talking about severe atopic dermatitis, then there is a role of oral immunomodulator also. Then you have dupilumab anti-IL-4, that is a wonder. The cost is 80,000, but even after paying 80,000 per month, it is not available in India. The only one company is making, that is Dupixent, all over the world. So there are patients in India, they want, they need, but it is not available. That is dupilumab. There are biologics, future is biologics, but after 5 to 10 years, after the cost will become lesser.
Sir, to find out the allergens which can trigger it in such cases where severe it is, peeling of skin is completely, peeling of skin, scalp, everything is there. How to find out the triggers, sir?
By history only. And if it is peeling, then it is not likely that it is atopic dermatitis. In atopic dermatitis, you have scaly lesion, VP lesion,
Yes,
edematous
Ken
papules.
syndrome.
So
Okay.
you have to identify triggers by history. Identify, you take a detailed history. What are the triggers? Some dhoop, agarbatti, house dust mite, carpet, old mattresses, then fungus in the wall, leaky walls, cat exposure, cockroach exposure, irritants, whether child is living in polluted area, industrial area or not, everything you have to ask. And
Okay.
atopic dermatitis, there is a very limited role of allergy testing.
Okay. Thank you, sir.
As
I
Dr.
have
Krishna Mohan said, you have to identify the PID. If child has presented with very early infancy, 2 months, 3 months,
Yes, yes.
then and if it is severe and IG is very high, 2000, 3000, then think of Viscot Aldrich or hyper IgE job syndrome, stage 3 docket deficiency.
I just
Okay.
have one question. If we have done an SPT and it is positive, then we do not really need to do an immunocap also for the same allergen. We can just test it by SPT alone and it's fine.
Yes, where you cannot do SPT, like patient is on
Okay.
antihistaminic, oral histaminic, severe atopic dermatitis, where you don't have any skin, application of local steroid is there. Immediate after anaphylaxis, you cannot do SPT. So there we can do specific IG by FIA, that is fluorescent enzyme immunoassay, that is immunocap by Thermo Fisher.
Which is the preferred one?
And
Like
yes, I
according
want to
to
highlight why
practice?
I want to tell one thing. There is no role of IgG intolerance in food taste. There is no role of ELISA test. That we come across to the lots of reports with that ELISA testing. Lots of allergen 80, 90. We also
Not.
select only 5 to 10 allergen for the SPT according to the history.
So which is the preferred one, immunocap or SPT? Wherever SPT is available, that should be preferred over the immunocap, right?
Because it is very quick, cheap, and cost effective. And gold standard because we find the bound IG that are set on the mast cell. With allergen, there is a cross linking. And free IG, it is little bit more sensitive, but specific is SPT.
Right.
Also, sir, there is a availability of CRD now.
But after SPT, immunocap, we want to stratify the risk, major allergen, minor allergen, cross reactivity, oral pollen syndrome. Then we go for the CRD.
Thank you, sir. Thank you, sir.
Thank you very much. It was an excellent presentation. Mitesh, I congratulate you for the selection of the cases. It covered all the common things that we see in our OPD practice. And thanks to all the panelists who have done a wonderful job today. Special mention to Dr. Krishna Mohan sir for being present here and guiding us and giving his valuable comments. I would like to thank Dr. Kamar sir and Dr. Samir Bhai for starting this webinar series. Every month we'll get to learn something new. Thanks to all who are present here, Dr. Ramesh Bajania sir, and my co-host Dr. Jigen Bhai, who is always ready to pitch in and help.
Thank you all for listening us.
Thank you. Good night, Samir
Thank
bhai.
you.
Thank you very much.
Good night.
Yeah.
Good night.
So
Good night.
Good night.
next
you.
we will definitely meet on the next third Tuesday of the month. What we are doing, and next we will planning with our environmental chapter just newly formed like the allergy chapter. and we will get you some more insight on that. Thank you.
Thank you.
Thank you,
very
Samir bhai.
much.
Thank you, Jagdish bhai.
Thank you. Thank
Thank
you
you
very
all.
much. Good night to
Thank you,
everybody.
Good
Anjalika
night.
Ben. Good night.
Mitesh
Good
bhai,
night.
excellent. Thank you so much. All the panelists
Thank you,
were
thank
very
you.
good.
Yeah.
And then a comparison of cases were very useful, as Angelica said, in day-to-day practice. So
Thank
please
you.
continue good work. Thank you so much, AOP Gujarat.
Good
Okay.
night.
Thank you. Thank you.